Let's talk about digoxin toxicity. What are the clinical features, classic investigations, and what's the treatment? Also, I'll talk about when should you give the digifab, digoxin antibody fragments. So let's start with the clinical features. The classic clinical features of digoxin toxicity involves the GI tract, heart, eyes, and sometimes nervous system. The initial manifestations are nausea, vomiting, and diarrhea. The cardiac complications or manifestations of digoxin toxicity includes atrial tachys with AV block. This is the most specific type of arrhythmia that suggests digoxin toxicity. Atrial tachys with atrioventricular blocks. Additionally, you will also get ventricular bigeminus. Some patients will have atrial tachyarrhythmias, and some will have ventricular tachyarrhythmias. Digoxin is a potent stimulant of the vagus nerve, and that can lead to a significant bradycardia along with the AV block. So bradycardia and AV block are common in patients with digoxin toxicity. The patient can also report a yellowish vision or altered color vision. Some patients will have headache and some will have confusion. So in patients with digoxin toxicity, it's very important to get an ECG, especially a 12-lead ECG, to identify the arrhythmias suggestive of digoxin toxicity. Electrolytes are also essential, especially potassium and magnesium, because hypokalemia increases the risk of digoxin toxicity. ABGs are essential because if the patient has acidosis, that's a bad prognostic feature. In patients with digoxin toxicity, a severe toxicity, there can be hyperkalemia as a complication of the toxicity. So hypokalemia increases the risk of digoxin toxicity. And whenever the toxicity happens, there is hyperkalemia, or there can be development of hyperkalemia. And obviously, we have to do all the general investigations. Treatment: hospitalize the patient, put him on a cardiac monitor. If the timing is less than 1 hour, so if the patient presents within an hour of taking overdose of digoxin, you have to give the activated charcoal. The patient should have correction of any hypoxia, correction of electrolyte imbalances, such as hypokalemia, hypomagnesemia. And we also need to correct the acidosis. The cardiac complications of digoxin classically includes bradycardias and ventricular arrhythmias. If the patient is bradycardic, we can start treatment with IV atropine. And the usual dose is 2 vials to 4 vials, so 1.2 to 2.4 milligrams. And if atropine is unable to control the bradycardia or unable to take the rate to normal, then we can also give temporary pacing. If the patient develops ventricular arrhythmias, we have to give IV magnesium. In patients who have significant poisoning or severe poisoning, where there is severe ventricular arrhythmias not responding to magnesium, severe bradycardia, so ventricular arrhythmia and bradycardia, then we have to use the digifab. This is digoxin specific antibody fragments. Those are monoclonal antibodies against digoxin. So we calculate the estimated dose, and then we give half of that estimated dose of digifab. And most of the cases, this is very effective in reducing the level of digoxin and reducing the cardiac toxicity. So in this video, I have talked about digoxin toxicity, what are the clinical features, classic cardiac findings, investigations, and treatment, especially when to give digoxin specific antibody fragment. Remember, bradycardia and ventricular arrhythmias. Thank you all. Don't forget to